Welcome, everybody. My name is Tony Gasparis. I'm the Chief Medical Officer for Tactile Medical, and I want to welcome you to tonight's webinar, an educational program which is supported and sponsored by Tactile Medical. Today, we're going to be talking about chronic edema and how we can help as far as transforming your practice and managing these patients with a chronic condition. And Tactile is dedicated in the management of patients with chronic conditions, obviously being the leading companies with lymphedema management with intermittent pneumatic compression. Tonight we have several speakers with us. Jennifer Clark, she's a physician assistant out of Piedmont Vascular, Dr. Manu Aggarwal, and Dr. Jeffrey Schoonover. And please proceed with any questions that you have. Submit the questions through the Q&A icon at the bottom of your screen. We want to keep this interactive and obviously help answer your questions and help really improve your clinical practice through this webinar. So we can get started, and I would like to get Jennifer Clark. Can you get her slides up? And Jennifer works in a very busy cardiovascular practice, a good friend of mine, Louise Leon, and she's going to talk to us today about lymphedema and how she manages as far as these patients in a busy practice. Go ahead, Jennifer.
Thank you so much, and thank you guys for joining us this evening. Again, my name is Jennifer Clark, and I am a physician assistant. Nick, if you could advance the slide, please. And I am currently out of Tucson, Arizona, and I'm a part of a very, very busy cardiovascular practice. I've been with our group now for about 5.5 years. We have an office filled with cardiologists, all different types of cardiologists, as well as vascular surgeons. And so I work with the vascular surgeons. My background, I've been doing vascular surgery in my career now for about 13 years. I've been a PA about 17 years. And I'm also our vascular director. I am prior Air Force, and so I got a GI Bill and thought, hey, maybe I can get an MBA with this thing. And so since I've gotten that, I've taken on an administrative role as well. So I've been in Tucson now for about 5.5 years. And when I joined this practice, having had a lot of experience in the vascular world prior to joining it, we definitely saw some areas for improvement, particularly with lymphedema patients. And so next slide, please. So my training for venous and lymphatic disease was actually pretty extensive. I joined a vascular surgeon right after I got out of the Air Force. And my training started with really just understanding the disease process. So I was really given a lot of opportunity to start with just clinic and understanding venous disease, both superficial and deep, as well as the complexity of lymphedema before I started doing any procedures or anything like that. And it's interesting, as we were kind of preparing for this talk, the panelists and I were discussing how different states have different ways that they utilize APPs. And in Arizona, there's a lot more freedom for us than other places. So I am actually a practitioner who does all of our superficial venous procedures, from RFAs to venous seal to varithena to fluidectomies. And so I have a very busy vein practice myself, mainly because of the surgeons that I work with. Their focus is mainly arterial, and they needed someone to kind of step in and take over that. And so that's what I do. And that started really with an extensive background of just understanding the disease process. And then I eventually started doing things like sclerotherapy, and then it was ultrasound guided sclerotherapy, and then fluidectomies, and then procedures. And then
Jennifer,
yes.
So my guess is that during your training in PA school, you didn't get a huge exposure in vascular, never mind venous and lymphedema.
Right, exactly.
So how, joining a practice that's busy arterial practice, how did you get that education?
Right. So my initial practice that I joined right after I got out of the Air Force was a vascular surgery practice, but that particular surgeon had a passion for venous disease. And so he taught me everything I know. And I was with him for about 5 years. And then, so basically, just kind of starting reading a lot of books and then learning through clinic and then gradually through hands on experience. And so that's how I did it. And then, so when I came here to Tucson, I already had a very big background in venous, and so just kind of meshed right in and was able to bring a lot to this practice that was missing, in particular in the field of lymphedema. So, which actually kind of transitions us to the next slide, which, if you don't mind, Nick, the big gap in treatment that I saw is I feel like in a lot of practices, lymphedema is kind of like the redheaded stepchild, if you will. Like nobody really wants to deal with it, and so a lot of people will just send them, well, you must have a vein problem here, go see somebody about your veins, and here's a diuretic, and that's all they do for them. And so when I joined this practice, the first things that I thought we needed were really a good lymphedema team. So we currently, like when I first joined 5 years ago, we didn't have any relationship with a company like Tactile Medical. We didn't have any lymphedema therapists that we could send our patients to. And so I went around town and I vetted out different lymphedema therapists. We got in touch with Tactile, we brought it in. And then with me kind of implementing that in my own practice, I was able to then share that with our vascular surgeons and cardiologists. And now, everybody's ordering pumps and therapy for patients, which is a really much needed thing. And it's a nice synergy that we have because we have cardiologists who have a lot of patients with heart failure. And they're, helping. We work together very cohesively with making sure we've got a cardiac clearance for those patients to be able to use lymphedema and pumps and therapy and whatnot. So that's been a very, very positive change that we've had
So
as far as our practice.
can I ask either you or Manu or Jeff? I mean, that was an interesting comment you made as far as partnering with somebody that can help you build that practice or at least help you manage these patients. How did you build up within your practices that collaboration? And obviously, biased a little bit here, but Tactile is a good partner as far as trying to help manage these patients and provide the care that they need.
At least for my practice, Tony, we were seeing a significant amount of folks coming in with just chronic leg swelling initially. And I think for anyone that's out doing venous care and such, I've been just trying to pivot folks and have them step back and say, okay, when you have the swollen leg, you should work it up appropriately first before just jumping on for the venous procedures and such. In doing so, we had brought on now we have two lymphatic therapists, but we started off with just a part-time on-site PT initially, and then just grew it up over a course of 5 to 6 years. And they work in tandem with my two nurse practitioners in a really wonderful way.
Yeah, I think in our practice, we did a similar concept as Dr. Schoonover is talking about, is identifying those patients early on because they're coming to you with lower extremity edema. And then we actually started coordinating with the local hospitals, with the certified lymphedema therapists that were there, and kind of figuring out, what are they seeing? We incorporated, vendors like Tactile, like Lymphopress, like compression garments like Juzo and Sagvaris, and, started really trying to educate ourselves a little bit more because there's wonderful education platforms on all of these vendors' sites. And then, of course, talking to colleagues and each other about what we're seeing in our practice.
Sorry. So Jennifer, you're doing when you see these patients, are you the first person that's seeing them, or you typically managing their follow-up? I mean, how do you work them up?
Yeah, so it actually varies. It's any and all. I have I have a lot of patients that I see as new patients and take them all the way through. I have a lot of patients that like our cardiologist will send us for leg swelling, and they will have already ordered an ultrasound for us. And then sometimes, they'll not have any real guidance as far as what to do for their swelling after they've maximized what they could. And so then they'll send them that way. But so it's kind of a big mix, but it's been nice too, as I've joined the practice and really brought in tactile to your guys' points. It's been very nice to be able to give the educational resources to providers who previously didn't know really how to manage it outside of just what the basics were with compression and, and then again, most of the time inappropriately prescribing like a diuretic or something and then kind of throwing their hands up. So it's been really nice to be able to partner with Tactile and others just to really provide that education. But yeah, I see a big mix of it all for sure. So then the next slide that I had was just really, again, looking through our workflow. I didn't get too into clinical stuff with my part of the presentation because I know our other panelists are going to dive into some of that. But next slide. Again, when we're looking at how do we teach people to, whether you're an allied health professional or you're a physician wanting to incorporate, a nurse practitioner, a PA, definitely, I think the big things that I would advise from a perspective of being a PA who had to learn how to do all of this is certainly helping them to understand the why behind what you're doing. I've seen a lot of people make the mistake of just bringing someone in and kind of throwing them in with the wolves, if you will, without really helping them to understand why they're doing what they're doing and just all of the information behind it. And so that being said, just a very brief overview, and I know we're going to get into some more details as far as workflow, but really just thinking about the whole big picture of the patient is something that we should be training, ourselves and staff that work with us as far as an evaluation of these patients, like looking from a venous perspective, if they've had a history of a blood clot in which leg, do they have anything that could be impacting their calf muscle pump function, looking at their physical exam, and again, having them actually take their pants, their shoes, their socks off to look at these legs, look at their belly, make sure we're looking at the whole big picture, looking with ultrasounds, and then really understanding, because of how complicated lymphedema can be and all the different things that can contribute to it, having a good mix of differential diagnoses in the back of your mind when you're talking with that patient, and really being able to decipher what the main underlying culprit could be. And so those are definitely things that I would highly recommend that are being considered when you're training up someone to join your team regarding, managing these patients. And then again, just really finding people in the community. I think it's awesome to be able to have therapists on staff, but if you don't, making sure it was a very, very good exercise for me to actually go out and vet multiple different lymphedema therapists in town. And to be able to have that as a resource for our patients has been very, very valuable. Next slide. I think that's basically the big advice and insights that I have, but I think the real focus on the comprehensive history behind one of these patients, as we know, they're very, very complicated. So taking the time to invest in an education for all of the things that contribute is definitely, I think, my biggest advice. And don't be afraid to get out and kind of put on a pump, go meet the therapists, and, certainly engage with companies like Tactile, who have just a plethora of information to provide for your team. Anybody have any other questions from me before we go on to the next section?
Jennifer, did you do your training for PA school in the military?
I did, yeah. So I went through, it's called the Inter-Service Physician Assistant Program. It was a very wonderful program. So Army, Air Force, Navy, and Coast Guard all go together, and it's partnered with the University of Nebraska Medical Center.
I was at Randolph, and so that was when I was in the military.
Nice.
Yeah, and that was my first introduction, having a PA, and nurse practitioners and such. And I can't underscore, that is just such a premier program. And thank you for your service.
Oh,
And
thank you.
yeah, it's a wonderful thing making that connection, but it really is part of the reason why I had brought on APPs in my practice, because I was comfortable with that in the military.
Yeah. Yeah, it was a really, and I feel very fortunate as I precept a lot of PA students that are coming through some of our universities here in Tucson. And I think I'm very fortunate that I had a very surgical heavy clinical rotation where not all programs do that. So that's definitely something to consider too when you're bringing people into the team, like how much of a background in surgical specialties, even a vascular surgery is very small niche of surgical specialties. And I unfortunately didn't have that exposure, but because I had so much other exposure in my training, I thought that really helped me kind of dive in and understand it.
Outstanding. Thank you.
Excellent. Well, thanks, Jennifer. I'm sure we'll have some more questions as we move along. And Dr. Aggarwal will now talk to us a little bit about how empowering your practice with APPs.
Thanks, Dr. Gasparis. If you could go to the next slide. So, as we all know, lymphedema is a chronic disease that affects quite a number of our patients in our practice. Our practice is located in Lima, Ohio, lost in Middle America. There is a documentary if you want to watch it. And so we do have a lot of patients that come to our practice with, of course, swollen legs. And as we all know, from a scientific standpoint, and also from just a quality of life, mobility, and so many other factors that we look at, it's really important to recognize these patients early on. And so when I joined my practice 14 years ago and joined and saw all of these patients with chronic edema, we fixed their venous insufficiency, but they continued to have edema, or their lymphatics were not addressed. And as we all know, that if it keeps going on, these patients have a compromised immune response, they develop recurrent skin infections, inflammation, and then eventually they can develop skin breakdown and ulcerations. And so I think it's really important that practices not only really even in the venous world, but really practices across every aspect of medicine, whether it's cardiology, as Jennifer talked about, even nephrology, surgery. I mean, really lymphedema is a condition that a lot of practices and a lot of specialties see. Can we have the next slide, please? So I think I wanted to include this slide just to basically show you, I love the picture that don't let this become this. And I think that is the biggest issue that we see in our practice is a lot of the times we see the become this part and we're missing the don't let this part. And so a lot of times these patients are coming to us so latent in their disease process because the chronic edema and the chronic skin changes have been ignored for so long. And so I think you guys are probably already seeing these patients in your practice. And I think it is a wonderful opportunity for us to make a very strong impact in these patients and also educate your community and other physicians and APPs in the community that are taking care of these patients so that you can kind of get a handle on this early on. Can I have the next slide? So basically the way that we look at lymphedema is literally we throw the kitchen sink at it. And what I mean by that is we are making sure that we're recognizing the disease process early. Anytime a patient is a self-referral or if it is referred, we are identifying these patients early on and we're getting everyone involved from day one, meaning we are picking up the phone or we're sending a fax, whatever it is that we need to do to get our certified lymphedema therapists involved. So we have our own certified lymphedema therapist in our practice, but that doesn't mean she sees all of our lymphedema patients. We try to coordinate with all the other local therapists so that the patients can get CDT and MLD with the therapist that's closest to their house and also closest for them to be able to travel to and attend based on work schedules and things like that. We're also getting them more aware of compression garments. You know, as we all know, in January, that has all, Medicare does cover compression garments for lymphedema. And so oftentimes with these patients, we're getting them started with just awareness, because oftentimes they will get a nice reduction pretty quickly with their CLTs. And so then we don't want them to necessarily have a compression garment and then 4 weeks later they're.
Just to highlight another point there, Tony, Dr. Aggarwal does such a great job integrating with the different resources in the community and such. We see a geographically separated population too, and we've had a lot of success with using one of our local hospitals and that from even getting some of the lymphedema garments issued and paid by insurance, because it's been great with the Lymphedema Care Act, but obviously it's a lot different for making sure that insurance coverage is taken care of. And so working with that hospital has helped out significantly.
I was just going to caveat on that too. It's very interesting, like the different states and the different obstacles that you have to overcome regarding lymphedema care. Arizona, we still struggle with getting insurance to cover compression garments, and also lymphedema therapy. We only have a handful of therapists that we can actually use with insurance coverage. And so that's another good part of vetting in your community, what's covered and what's not, and what resources are available for those patients, because that can be a real challenge for sure.
It's from working the insurance credentialing aspect. If you do bring on a lymphatic therapist, absolutely, you got to be checking those boxes off, because it varies so much. And I know some states, you know, you can definitely go the PT/OT route. Some of the other ones, it can be an RN that can use those codes and that, but it's you have to do that type of homework well before you bring a CLT onto your staff.
So Jeff, and Manu, how do you guys manage from a business perspective incorporating lymphedema therapists into the practice?
They're employed for us. As we were kind of going through the practice management component and seeing what was going to work out from the insurance aspect, we actually used a model very similar to one of the orthopedic offices close by, and it's been successful for us. I do tell folks, you know, it's not going to be a super revenue driving service line, but it's right for the community. And, you know, we still are in the black for it, which is good, but it's still, you know, don't expect that there's a huge amount of reimbursement with it. It looks like Dr. Aggarwal's back online there.
Sorry,
Good.
again, lost in Middle America. So I'll continue on here. Thank you. So compression garments, definitely a discussion at the very first visit. We're also figuring out with the patient and, you know, just putting a little bug in their ear. What are their dietary habits? Are these patients really needing to be evaluated from an endocrine standpoint? Do they need to be, you know, on a GLP-1 for their weight issues? Do they have a recent echocardiogram? Are we dealing with heart issues? Are we dealing with kidney issues? And then we're also talking to them about pneumatic compression devices. And so we kind of throw all of this at the patient. We have these nice folders that has everything in there for the patient, so that they can take it home with them, look it over. What is a pneumatic compression device? What are compression garments? What are some anti-inflammatory things that I can incorporate into my diet? And, you know, also weight, because a lot of times these patients have struggled with their weight management as well. You know, and so most of the time, I know Dr. Gasparis was asking, you know, Jennifer, do you see all the patients? I typically, in conjunction with my APPs, so I have 2 nurse practitioners in my practice, that we work together to evaluate, and then throw all of this at the patient, and then see these patients back usually about 4 to 6 weeks after they've started therapy, because we really want to make sure that these patients are responding to therapy quickly. And then we're also talking to them about skincare, and making sure that they're getting into compression garments for the long-term management of their disease process. Can we have the next slide, please? So I just wanted to throw in some before and afters of some of our patients that we've had sent to lymphedema therapy. Some of this is also lipedema. So you will see a lot of patients with concomitant, not only venous disease, as well as cardiovascular, nephrology, so many other disease processes. But a lot of these patients even have lipedema and lymphedema in combination. And the slide on the right, I really wanted to include that because, you know, looking at that leg, sometimes maybe the primary care physician, you know, may tell this patient, it's not too bad. You know, it's really not too terrible. You just have a little bit of swelling. You're just getting old. And so a lot of times, you know, these patients do have what looks like minimal swelling on the outside. But of course, when you're scanning them and you're looking at them, you see these pillowy, you know, echogenic kind of things in the ultrasound, and, you know, you really see the edema very clearly. And so a lot of these patients have chronic edema because of even just chronic bony changes and arthritic changes. You know, we see a lot of patients that are like, well, I'm getting ready for my knee replacement. You know, I have a lot of swelling or a hip replacement. And a lot of times we'll get these patients started with lymphedema therapy because the orthopedic surgeon wants to make sure they don't have any venous insufficiency or underlying DVT or anything like that. And so we'll get them started, and they usually do a lot better post-surgery. So, and then next slide. Yep. We also talked to them about vascular. So these are, again, just some patients that have done the vascular in our practice. It's an FDA-approved hesperidin diosmin product from Primus Pharmaceuticals. Usually costs a patient about $40 a month. You can get this product as well on Amazon. Not vascular, but the ingredients. But that is also something that we talk to patients about as well. And next slide. Again, pneumatic compression devices. This is something that you're going to basically give your patient as a solution to their long-term problem. You know, the patient's going to have this at home. They can't keep having therapy over and over and over again, obviously. Now, patients will wax and wane for the rest of their life. So we've had patients come in a year or two later, and they're like, I'm really out of control right now. Can I go back to therapy? So they will come back and do therapy, but they will still continue to use their pump at home. So you really need to kind of look at pneumatic compression devices, compression garments, skincare, diet, all of these little sort of arms that will help the patient manage their disease process long-term. Next slide. So I know the biggest thing that we're talking about today is why APPs. So in my practice, I love having my APPs because what they are able to do is obviously collaborate and coordinate with me by their side, of course, and commence the rest of the team that these patients need to manage their long-term sequelae, obviously. It also allows me to free up my schedule to do procedures. And so you have to kind of really look at what is your skill set? What do you bring to the practice? You know, I'm in private practice, just like Jeff is, and you really start to see where you can utilize your APPs in your practice to help manage these patients and free up your time to do procedures that are going to generate some revenue. Obviously, like Dr. Schoonover is saying, this is, lymphedema therapy is not a revenue generating profit thing at all within a practice. But it also gives your APPs an opportunity to grow their skill set within your practice and sort of become advocates for your patients who have lymphedema. It is a high area of burnout. My lymphedema therapist, we're just talking to her last week. She said, I'm a little burnt out. What can we do? So we're working with her schedule to see, what can she do to continue providing the care that she does for our patients. It is something that you're going to have to hold hands with a little bit for your patients. And that's where, together with the APPs, you are really able to do this together. And, really the APPs have really helped in my practice, not only to manage these patients long-term, but also allow us to see more patients and coordinate their care a lot better.
That's what you were mentioning earlier that, both you and Jeff are in private practice and utilize APPs, obviously, in a positive fashion, without necessarily taking a financial hit. I think that's goes across no matter what practice it is, whether it's private or employed, just because of a lot of the points you mentioned, increasing productivity of physician. Obviously, you have to be busy enough to be able to grow. And there may be situations where maybe a practice doesn't grow because they're not doing the right things to grow, whether it's from a marketing perspective or whatever, just oversaturated area, whatever it is. But if there is, volume there, it makes absolute sense because, I mean, I'm in an academic location, state hospital, and I had 3 APPs working with me.
Yeah.
1 NP, 2 PAs. And, every time I would hire somebody, my productivity would go up,
Right.
20, 30, 40%, just because of increased abilities to streamline patients that need more chronic care, hand holding, and freeing up myself to be able to see, newer patients and do procedures.
Yeah, that's a great point. I mean, I think sometimes I feel like we're running a swollen clinic, like just every day. I mean, I think this week alone, we probably sent out 5 to 7 requests for pneumatic compression devices. I mean, it becomes, because you also have these extra providers in your practice, you start to become the place to go to for any leg issues that are pain related, but also you start to identify these patients with other disease processes that are kind of going on. So.
All right. I think that's your last slide, right?
Yep, I think I just have one more, and that was just, I'll just quickly summarize this slide. Basically, I think it's really important if you're going to tackle this is to educate yourself, first of all. Get your notes in your EMR, because you're already taking leg measurements, but you're gonna probably need to start taking abdominal measurements if you're not already. What kind of appointment types you're gonna have, intake forms. Do you stock compression stockings? Do you not? You wanna align with those people that are listed there. You wanna make sure your staff is educated all the way from your front desk, all the way to your back. Advocate, patients as well as your practice, APPs. And daily review. That's really important. We do that on a daily basis, and then every month we review at least 5 to 10 patients at our monthly meetings to just kind of go over and see what we've accomplished.
All right. So our last speaker for tonight, and I'm just reminding everybody, any questions, please feel free to put in the QA box. So Dr. Schoonover is going to move on and talk about how the impact of incorporating an APP for chronic edema in your practice.
Thank you, Tony. Nick, if you want to go ahead and just go to the spiral slide there. I just want to start off on that one. Again, throwing it up one more time. This is a chronic issue, folks. And really, identification of this early on, we're trying to minimize going to this fibrosis component. And really that was at the root of all of this, adding on the lymphatic therapist for our practice, as well as how we're integrating our APPs as we're taking these folks through. The next slide, and actually this is a fun one for us because we actually have this up in our office. And as you're looking at training, whether it's a PA, NP joining you, these are core features that, anyone that's onboarded, we run through it. And again, it starts off with getting that medical history, look at hospitalizations, COVID history, autoimmune conditions. And and hats off to my MPs, we've actually found a significant amount of folks that, actually had an underlying component of rheumatoid arthritis, it's out there, but if you don't consider it, you aren't going to get those folks going down those right pathways. For our EMR, and just like Dr. Aggarwal had mentioned too, we're trying to capture these quality of life impact scores as well. Not only just seeing the ADLs, but as appropriate, plugging through VB-SymQuick. We use the lymphatic life impact score at the baseline and at the end of therapy to show the improvement for the patients. Obviously looking at the previous surgeries and treatment as mentioned earlier by Jennifer, and then social history. The thing that's been a big hit, and hats off to Tony for putting this in this article here. I love this medication slide. You would not believe how many patients we have that we make the suggestion of having them come off of amlodipine in particular. And it's such a great step in the right direction. Oftentimes, yes, absolutely. Their kidneys have been flogged with diuretics for multiple years, but that amlodipine component, take a look at that. Get a good medication history. Hormonal supplementation, including corticosteroids, absolutely plays a role. The gabapentins, those medications, it's not considered often, but a lot of times these chronic folks with pain in that are on that type of medication. Maybe there's an alternative. Folks that have had a history of chemotherapy, that obviously can be damaging of the glycocalyx, and that can be a permanent issue. It's always worth mentioning the NSAIDs, some of the different classes of diabetic medications, and that too. I think we'll go to the next slide there. When we're going through this with our team, I get them thinking on a systematic basis. Think about, okay, if you're hearing that S3, if you're finding the patient has AFib, if their lungs do sound congested, we want to work that up. The abdominal exam, absolutely. Especially for some of these folks that have had previous surgery and such. We did have a patient at one point that had a hepatitis C flare. And we, as we were taking them through lymphatic PT, it turned out, oh yeah, I had been through the medications and doing fine. And then lo and behold, his viral counts had spiked up. We've got to be also thinking from the arterial side of things. Our practice gets a fair amount of referrals from the dermatology offices in our area. And oftentimes they've been through multiple different medications in that, and capturing that history is just as important. The calf pump assessment, big help. As we do education in the community, I am always surprised how much folks do not know about the stemmer sign. And I know there's some argument about, okay, how clinically applicable it can be, but just take a look at the patient's feet. My goodness, these are folks who have been dealing with this for years, and it gives you such a great idea of that edema distribution and such. Labs and imaging, and as we look at it with my interactions with APPs and that, by all means, we can do the ultrasound at our lab and that, but we work in tandem with a couple of IR groups in our area. That will also help us out when we do think that IVUS or additional venography is indicated. Next slide there, Nick. This diagnosis pathway, again, hats off to Tony. This has just been a wonderful way to look at this too. Again, this is one of our educational pieces in our office. It just encapsulates this. One of the other things we did not mention, sleep apnea. That is actually can be a contributor, folks. Kidney and liver disease, protein malnutrition, pulmonary hypertension, thyroid disease. We have a very low threshold for ordering additional labs at our office if we think those boxes haven't been checked off already by our referring docs. That being said, this slide also shows that overlap with venous insufficiency, lymphedema, and lipedema. And I think it's just core with what you need to be considering in addition to this. And absolutely, these conditions can overlap in that. But again, if you're seeing someone for C3 and above venous disease, have that consideration that there's probably a lymphatic overlap for it. Next slide there, Nick. This is, as we've conceptualized how we're approaching how the lymphatic PT pathway works, we always want to highlight when first, our folks are first starting off, they're in that, we want to get them into that decongestive phase first, and then move them over to the maintenance phase. There's a lot of patient education that goes along with that, but certainly making sure that you're doing your part, getting those baseline pictures, measurements, checking off all the boxes. If you need to get clearance from other providers, particularly, any cardiology patient or folks have been through different kidney issues in that. It's, and I think actually it may have been Monica who brought this up, but getting that work, it's almost like the scut work that you had to do in residency, or doing that extra homework to make sure everything is checked off as we're taking folks through PT. And it also helps our physical therapists in feeling comfortable. Hey, we've checked off all the boxes medically before they're going through the treatment phase. In our facility, we will wait on getting the compression wraps and that set for the patient until they have been evaluated by our lymphatic therapist. And the additional wrinkle, of course, is with the Lymphatic Care Act and such too. Sometimes, because we are not a DME supplier, we're working closely with a hospital-based compression outfit that has made that a lot easier. Another piece of this slide too is always highlighting the nutrition and the role of MPFF therapy. It really does wonders for folks, and whatever medication route you look at supplementation wise for it, it's definitely should be a consideration. Let's go to the next slide there. This consensus forum, I like revisiting this, because, there are still some folks that think, oh, you can only make that diagnosis of lymphedema by doing the additional testing, lymphoscintigraphy and such. And really, 88% of folks agree, no, clinical exam is sufficient. In those folks in that C3 to C6 category, there were 72% that agreed these should be considered lymphedema patients. And that's been a big push. And even when we're educating our referring providers regarding this. Regular use of compression garments reduces the progression of lymphedema, 89% agreement. Again, compression is a big help. The use of the sequential pumps should be recommended for lymphedema patients, 92% agreement. I think that's, I always say anytime you get a group of physicians around, it's like herding cats. These are great, wonderful experts in the field, and they, to have this type of consensus, it's just awesome. And the last part about this is, when we're staging lymphatic folks, we do understand, yes, there's overlap and such, but these staging protocols are trainable. And, if for folks that, may not totally, there may be more of an overlap of, and may fall in the category of a lymphedema patient, it's still their support for taking folks through lymphatic PT is part of the conservative measures. And I think that's, the ultimate part about this is, hey, this is such a low-key, nice and conservative way to help out this disease process. We'll go next slide here. Practice pearls. Just from our standpoint for our provider team, we always big on getting these folks staged appropriately. And as folks look at adding on a lymphatic therapist to their office, try it on a part-time basis. Just go to the shallow end of the pool and just see how that works out initially. But I will tell you, if you're seeing a significant amount of lower limb swelling in your patient population, it's definitely a viable model. You have to be available to both your APP and lymphatic therapist, though. This is just not a one and done thing. For those folks that treated, asthma, high blood pressure, anything like that, you wouldn't just see them once and throw medications out. This is it is really a disease condition that deserves respect. And then my last part is absolutely, when you're taking care of the phlebolymphedema patients, be thoughtful about approaching ablation treatment. Just a small amount of reflux at junction is not a justification for doing ablation on these folks. I really think that's, we're getting more knowledgeable and the papers are getting better. A lot of these lymphatic folks, the best way to take care of them is actually by conservative measures. Next slide. And these kind of things that we have learned, and I always like sharing with it. You heard me talk about swelling. It does deserve respect with this, and we want to make sure to help out this patient population, you're seeing them in continuity. You got to be willing to do the additional labs, be it getting a CMP, thyroid studies, checking different heart issues. Definitely take a look at your patient's feet. But also know too, the lymphatic pump is only one piece of the puzzle. It doesn't totally replicate complete decongestive therapy nor patient education. Next slide. This is a collaborative care model. And thinking back to Jennifer's military experience, adding on APPs to our practice has been a force multiplier. It allows you to do more with having this type of team in place. It has definitely benefited my schedule and overall efficiency. But just be ready, this is still this type of patient. They are more susceptible to cellulitis and other recurrent health issues. So, just be thinking on your feet with this. When we're looking at adding on and where we're positioned in our community, we are drawing from a very large referral radius. And we ran the numbers. I mean, over 50% of our patients presenting to our practice have some component of edema to their picture, especially the folks coming from the farming communities and that. It really helps out this type of patient population. And by doing so, it does add horsepower to the practice. Next slide. And I think ready for the Q&A. Thank you so much.
Thanks, Jeff. We got a couple of questions as discussion here. So first question is from a lymphedema therapist and is asking how can they reach out to vascular surgeons and other physicians as well as far as helping educate them? How would you recommend they approach providing education to them, especially I guess those who don't necessarily know much about lymphedema and kind of, like you say, give them some diuretics or send them to their cardiologist or whatever. She goes on to say, my local vascular surgeons will comment to patients that the patient does not have lymphedema, and it's clear to them, to her at least, that they do. So obviously a disconnect as far as diagnosis between the lymphedema therapist and the arterial vascular surgeon.
I mean, I think it's really what I have found to be really successful is to reach out and kind of old school, pick up the phone, talk to the lymphedema therapists, and start to have, especially at the hospital level, having them talk to the departments that are involved, cardiology, nephrology, and really kind of making sure that there's some in-services going on. I think that's really important, but I think what has been the most successful in our practice is actually empowering the patients. So if you can, through your social media or through even flyers that you may give to other practices, we're doing presentations at your local, senior center, things like that, really kind of putting the education out there. You'd be surprised. I have so many patients that come in and they say, you know what, I think I have lymphedema, but none of my other physicians do or my other providers do, but I saw the picture on your website and it looks just like my leg. So.
I think oh, go ahead.
Oh,
No, go ahead,
Jennifer, you go.
Oh, I was just going to say, I mean, I think that it's interesting because that was probably one of the challenges that was the story of the practice that I'm in until I joined. And it was me actually as a PA kind of having that interface with the therapist. So my perspective maybe on that question, I know sometimes, especially with surgeons, they're very busy and a lot of them are like, swelling, I don't want to deal with it, so I just won't. But if they have a nurse practitioner or a PA that you can, get in front of, I think that would be a very good way for you to kind of bridge that gap with them. So that's my 2 cents there.
Or just send them to the Tactile website where they can find the educational videos where we discuss on evaluation and management of lymphedema. Jeff?
There's a staging handout too that we've used in those type of situations. And, I think folks, when they're recognizing a stage 3 patient, okay, that's a slam dunk. But when they're earlier stages, that's where the challenge of education's at.
Yeah.
And great resources on the website, definitely.
But there's really a big push in most of the society meetings, and a lot of interest when you go to those sessions on leg swelling and lymphedema. The room tends to be packed, and which is kind of surprising given that, especially the vascular surgery meetings, whether it's American Venous Forum or AVLS, they tend to have an overflow of people attending those sessions, which again may be an indication of lack of knowledge and trying to educate themselves. But because unfortunately, like was mentioned earlier, there's a lot of leg swelling out there. And how do you navigate those patients and identify which ones potentially would benefit is the most important part. And I think that's part of the education, it's not necessarily, Kristen, how do you educate the vascular surgeon is, but how do you want to kind of give them a reason to get educated, right? So the reason is identifying the right patients that would actually benefit from intervention and increase their volume. There's another question on, are presenters involved? I think this one is a pretty straightforward one. Are any of the presenters involved in education training the next generation of healthcare professionals? I'm hoping that we're trying to do a little bit of that here tonight. And if you do so, do you speak to the value of the APPs and therapists, which I guess, again, this is what kind of we're doing here tonight. Jen, you want to take it? You mentioned that you actually have students in APPs.
Yeah, we have physician assistant students that come through with us, and we have residents as well. So, and then, just getting involved with different companies and everything, conferences and things too, to be able to spread the word, because it's so important. Especially, I think just really trying to arm those APPs with all the knowledge that they need to be able to take care of these patients. And just one little caveat that I was thinking about as I was listening to our other presenters talk is just making sure that we're also training these APPs with how to manage expectations with these patients, even after, if they do have significant reflux and they're having a vein procedure, what to expect, with how that impacts or may not have a huge impact on their lymphedema, and just the chronicity of it and how they can really help manage that in the long term for these patients. Because a lot of people, they want to know why it happened. They want to pinpoint specific answer to why they have swelling, which we may not be able to give them. And then they want to know, how come I can't make this go away completely? And so those expectation managements is another thing that I definitely think we should be educating quite a bit on.
Yeah, but I think the comment or question was more on educating the physicians early on of the value of an APP in their practice. And Jeff, you mentioned earlier that you were introduced to APP, when you started off in the military.
Absolutely. Yeah. And
I think most of the trainees these days that, they're going through residency and fellowship, and they're the worker bees. They're not necessarily interacting as closely with the APPs or at least being taught to interact and work as a team.
I really look back at, and it was that collaborative model in the military it's the framework of why our office, it's in the DNA of our office right now. And even looking back, we have high school folks rotate through for a few weeks to just introduce them to these concepts. And I mean, it's just, when I talk to any of the physicians in the community, I think there's more receptiveness to understanding, being willing to work through the concepts of lymphedema than it is with some of the folks closer to retirement. And probably it's just, more subject exposure in that, but it's hard. I mean, this is it's a growing growing area of helping build understanding. And, we just want to help these folks out.
Yeah, no, I mean, any comments, Manu?
No, I think that really getting involved in your community, whether, just like Jeff said, having high school students rotate through your office for a shadowing experience, speaking to we have a residency program here that's community-based, making sure that you're listed as one of the speakers. So I think it's, just getting out there really is important.
Sounds good. Any last minute comments from everybody as we're wrapping up here? Well, thanks a lot. I think obviously healthcare is transforming every day. And the topic here is transforming your practice. I think using APPs to maximize productivity in physician offices, as well as really, I think, providing a solution for patients who have a chronic condition that really has a value, and not just from a tactile medical perspective, which they do a great job as far as providing the resources to help practices kind of offload these patients and provide home care for a chronic condition, but also using your APPs to navigate those patients through your practice and obviously increase your own practice productivity. So I want to thank obviously our great panel of speakers and Tactile Medical for this webinar. And I would like to enjoy the rest of the evening. Have a good night, everybody.
Thank you.
Thank you.
Bye-bye.